Bismillah ar-Rahman ar-Rahim. Today we are going to have our presentation about introduction to thyroid gland. This will entail half of the lecture, approximately about anatomy, followed where we are going to tackle these points. However, we are going to start, inshallah, with embryology and anatomical side. First, we have to have a few minutes with this very important diagram as regards the embryology of the head and neck. As we all know, embryology of the head and neck is derived, of the neck particularly, is derived from branchial apparatus, where there are 6 arches on both sorry for that, where there are 6 arches on each side, 1, 2, 3, 4, and 6th, where the 5th one develops a normal accidental vascular accident, and it disappears. What concerns us in this lecture as regards the embryology of the thyroid gland and the parathyroid glands is the 3rd and 4th arches, where, as we can see from the 3rd arch, parathyroid and thymus glands will develop. However, from the 4th arch, the superior and altimobranchial body will also share in the development of the thyroid gland. However, these will come in details later on. What concerns us very importantly now is that the thyroid gland here arises from here, from a bud from the pharyngeal wall in an area which will be the foramen cecum in the adult life, that is the junction between the anterior 2/3 and posterior third of the tongue. Then this thyroid gland from this area starts its migration through what is known as thyroglossal duct to reach its final destination in the lower part of the front of the neck. This descent occurs through this duct, which we can virtually imagine it as if a hollow tube having an upper end at the foramen cecum and a lower end down at the lower part of the front of the neck, where the thyroid gland enters from its upper end and appears in its lower end. Then the thyroglossal duct itself disappears completely. And through the altimobranchial body, which is present here in the 4th branchial arch, and shares in the embryology of the thyroid gland. What is the altimobranchial body? Altimobranchial body is a collection of neural cells migrating from what is known as the neural crest. The neural crest is the part which develops in early life into the nervous system. However, some cells from this neural crest migrate into different parts of the body to reside in the junction between the dermis or the epidermis, for example, forming the melanocytes, in the GIT or bronchi, forming the Apud cells, or the cells which will develop one day if something goes wrong, the apodomas. The most important example of them is the carcinoid tumor, and it resides in the sympathetic trunks. It resides in the adrenal medulla, forming the adrenal medulla, and from which a tumor very famous known as pheochromocytoma may develop one day. And what is important to us here, that some of these cells from the neural crest migrate to reside in the 4th branchial arch, as we can see here, forming a collection known as the altimobranchial body. Then, while descent of this thyroid gland, this altimobranchial body from both sides share and fuse with the descending thyroid gland, where its cells as if explodes within the acini, or between the acini to be precise. So it forms cells known as C cells, or calcitonin producing cells, or parafollicular cells, because these cells do not reside inside the follicle but in between the follicles. And this will be the origin of a medullary thyroid carcinoma, one of the malignant thyroid tumors that occur in about less than 5% of the thyroid tumors. And its origin from the neural crest cells migrating here to the altimobranchial body explains the importance of some multiple endocrine neoplasia tumors where the medullary thyroid cancer can be associated with other tumors, the most important of which is pheochromocytoma, as can be detailed later in the section of the thyroid tumors. The next thing is that the inferior parathyroid glands, as we can see, develop from the third arch, and the superior develops from the fourth arch, in contrary to their locations. So the lower one will form the superior gland and the upper one will form the inferior gland. And we can see here the superior parathyroid glands develop from the fourth arch, so it will migrate a small distance in the neck. And so in most of the cases, it is residing in its original position. However, the inferior parathyroid glands develop from the third arch, and that's why they migrate a very longer distance to the lower part of the front of the neck, and that's why it's more common for the inferior gland to be ectopic than the superior one. Other cause is that the thymus gland accompanies the inferior parathyroid gland towards its journey to the lower part of the front of the neck, and then they separate where the thymus continues into the superior mediastinum. Sometimes this separation doesn't occur, and both glands migrate into the superior mediastinum, and that's why one of the commonest sites for an inferior parathyroid gland being ectopic is in the superior mediastinum, together enclosed within the thymus, together with the thymus. We have a thyroid gland, the main thyroid tissue that is TSH dependent, that shares in the synthesis of T3 and T4 in the future, develops from this pharyngeal bud that descends, as we have formerly said, and then it is joined by the altimobranchial body cells migratory from the neural crest to form the medullary form, the medullary part, or the parafollicular cells, or the C cells, because it secretes calcitonin, which is used as a tumor marker for medullary thyroid tumors. And then we had a simplified clue about the embryology of the inferior and superior parathyroid glands and the thymus as well. Then as we can see in the next slide, that the thyroid gland is a butterfly-shaped endocrine gland. It's a very, very important gland residing in the front of the neck. In contact with the thyroid gland, its upper pole touches or becomes near to the or comes near to the oblique line of the thyroid cartilage, and going down to the sixth tracheal ring, formed of two lobes, while the isthmus is corresponding to the second to fourth tracheal rings. However, sometimes in more than 50% of the cases, we have as well a pyramidal lobe. Sorry for that. We have a pyramidal lobe extending from the isthmus upwards to variable distances, which might reach up to the hyoid bone. And this pyramidal part is present in more than 50% of the people. So it's not considered, as we have formerly said in the previous decades, that it is a congenital anomaly. It's a constant part of the thyroid gland because it's present in more than 50, sometimes 70% of the population. And the gland laterally touches or abuts the carotid sheath. So we have an idea about embryology and anatomical site. Next, we are going to tackle the blood supply, the nerve supply, muscles, and important structures related to the glands. As regards the arterial supply, and I will be a bit in a hurry here because these are just academic information that can be found in any textbook, is that the arterial supply of the thyroid gland is derived from the external carotid artery through the superior thyroid artery, and from the inferior thyroid artery from the thyrocervical trunk, first part subclavian. The venous drainage is through the superior thyroid vein, draining into the internal jugular vein, the middle thyroid vein, if present, into the internal jugular vein, and the inferior thyroid veins that drain into the left innominate vein, or sometimes they both veins of both sides may unite and form thyroideema vein, going into the innominate vein as well. This is a sketch which is very, very important sketch that shows us that the inferior thyroid artery is the main supply of the inferior as well as the superior parathyroid glands through branches, and that's why the inferior thyroid artery should not be ligated away from the gland, as the classical teaching was in many decades ago, because this will compromise the blood supply of the parathyroid glands as well. So we have to ligate the branches that are getting into the thyroid lobe parenchyma that is to be removed and not ligating the main trunk. And as we can see in here, and we will see in many other parts, that the recurrent laryngeal nerve is still in a very close position in the tracheoesophageal groove, as we will say in a bit later. This sketch shows us how the parathyroid gland, superior and inferior, blood supply is maintained while the branches going into the thyroid lobe are cut, and so the gland can be removed from the trachea, can be shaved from the trachea, leaving the parathyroid glands with their blood supply intact in the thyroid operative field, as well as the recurrent laryngeal nerve, of course. Nerves related to the thyroid gland, we can here just orient ourselves with the anatomy. This is the carotid sheath. This is the vagus nerve, from which a nerve known as the superior laryngeal nerve arises, passes behind the carotid sheath, and then soon divides into the internal laryngeal nerve and external laryngeal nerve. The internal laryngeal nerve gets into the larynx to be sensory supply for the area of the larynx above the vocal folds, and the external laryngeal branch passes in company with the superior thyroid vessels to supply the cricothyroid muscle, the only tensor of the vocal folds and the only intrinsic laryngeal muscle residing outside the laryngeal skeleton. It is found in a triangle known as Joll's triangle. We can Google its boundaries because it is beyond the concern of such a lecture for undergraduates, with all respect to my students. The other nerve arising from the vagus nerve is the recurrent laryngeal nerve. However, its origin differs from the right side and from the left side. On the right side, it takes off from the vagus nerve at the roots of the neck, winds around the subclavian artery, and gets into the tracheoesophageal groove. Where it enters the larynx close to the cricothyroid and inferior constrictors of the pharynx. On the left side, however, it takes off in the superior mediastinum, a bit lower than its colleague on the right side, where it winds around the aortic arch, and then it goes again into the tracheoesophageal groove, having a less steep angle, and passes upwards to enter the larynx as well, between the at the level of the cricothyroid muscle of the inferior constrictor of the pharynx. The recurrent laryngeal nerve is present in the Beer's triangle, as we can all see, and again we can Google its boundaries to know more information about this triangle. The recurrent laryngeal nerve in the anatomy, in the normal anatomy, is in the tracheoesophageal groove. However, sometimes during surgery, and because of the assistant pulling on the thyroid lobe towards the midline to facilitate this section here, the recurrent laryngeal nerve gets to a higher level, to be lateral to the trachea, not in the typical tracheoesophageal groove. Normally, it passes behind the branches of the inferior thyroid artery and then deep to the Berry's ligament. Sometimes there is what is known as Zuckerkandl tubercle or Zuckerkandl nodule, which is a normal enlargement in the middle of the lobe that either pushes the recurrent laryngeal nerve downwards, or more commonly it makes it just like a shoulder, where the nerve passes in between the tubercle and the trachea, making dissection much more difficult and tricky. The other anomaly, the next anomaly for the recurrent laryngeal nerve, which is not so uncommon, but it is extremely dangerous, that the nerve passes in between the branches of the inferior thyroid artery, not just deep to them. So while ligating these branches, it's very possible that this nerve will be injured. And that's why we have to be very, very cautious. The least common anomaly reported in about 2% of the people only on the right side, together with dysphagia lusoria or aberrant subclavian artery, is a non-recurrent recurrent laryngeal nerve, where it comes from the vagus nerve and enters directly into its point without taking off from the root of the neck. And this is again a dangerous anomaly, and that's why we have to be careful during ligating the vessels, the branches of the inferior thyroid artery. And so always we have to have the golden rule that a recurrent laryngeal nerve should be under vision while dissecting in the operative thyroid field from the start. The next point is the muscles related to the thyroid glands. What are the intrinsic laryngeal muscles? These are defined as the muscles that are responsible for mobility of the vocal folds. These are the adductors and abductors, and these are the tensors, the tensor of the vocal fold, the cricothyroid one. All the adductors and abductors, all the intrinsic laryngeal muscles, except the tensor, are supplied by the recurrent laryngeal nerve. However, the tensor or the cricothyroid muscle alone is supplied by the external branch of the recurrent laryngeal nerve. The extrinsic or strap muscles, they are defined as the muscles that are responsible for mobility of the larynx. And they are two straps. The superficial large ones are the omohyoid and sternohyoid. The smaller, deeper ones are the sternothyroid and thyrohyoid. And as we can see easily from the names of these four muscles, as well as the cricothyroid muscle, that muscles in the neck are named from down upwards. The nerve supply of these extrinsic muscles are ansa cervicalis, and the action are to stabilize the hyoid bone during deglutition, or to move the hyoid bone. So till now, from the anatomy section, we have come through the embryology, anatomical side, blood supply, nerve supply, muscles, and important structures related to the gland. We have a few points in the anatomy to go for. These are the lymphatic drainage, and as we will see in the lecture of the cervical lymphadenopathy given by one of my esteemed colleagues, inshallah, that the lymph nodes of the neck are divided into specific areas known as organ-specific drainage classification. So these include levels 1, A in the submental triangle, B in the submandibular triangle, 2, 3, and 4, which were formerly called the upper, middle, and lower deep jugular lymph nodes. And these are the lymph nodes that are present inside the carotid sheath. And then level 5, and of course, level 2 extends from the skull base to the hyoid bone, level 3 from the hyoid bone to the cricoid cartilage, and level 4 from the cricoid cartilage to the clavicle. Level 5 are the lymph nodes that are present in the posterior triangle, and level 6 are the visceral or central group of lymph nodes that are present in between the midline anteriorly, the carotid sheath laterally, the hyoid bone superiorly, and the suprasternal notch inferiorly. And then level 7, which are present in the superior mediastinum. And we have a very short animation for these lymph nodes, again to imagine their presence. These are level 1, 2, 3, 4, 5, 6, and 7. As regards the thyroid gland, the drainage passes to levels 6 and 7 to start with. This means that level 6 and 7 lymph nodes are those which are known as the first echelon lymph nodes, or the sentinel lymph nodes for the thyroid normal drainage as well as the tumors. Then the lymphatic drainage goes through levels 3, then 4, then 5, then 2, then 1. And that's why level 1 is justified to be not cleared during surgery of modified radical neck dissection for thyroid tumors, for differentiated thyroid tumors, papillary and follicular. Because the modified radical neck dissection, as we all know, the classical one is the clearance of lymph nodes from level 1 to 5. However, here we usually do levels 2 through 5, skipping level 1 because it is the least level to be affected in thyroid tumors. We have to know a very small idea, a very simplified idea about capsules of the gland, deep fascia of the neck, and Barrett's ligament. As we all can see here, that the deep fascia of the neck is divided into 3 parts, not like any other part of the body where deep fascia is a single fascia. Here we have the fascia that surrounds the whole neck. This is known as the investing layer of the deep fascia. Then we have a posterior one known as the prevertebral fascia, anterior division known as the pretracheal fascia. This pretracheal fascia is the one that we have to severe to reach the thyroid gland. We have also the carotid sheath, which is derived from the deep fascia of the neck, and some authorities of anatomy classify it as a separate 4th deep fascia of the neck. As we can see, the lower limit of our dissection, of our surgery in the head and neck or thyroid surgery, the lowermost limit is the prevertebral fascia. And after the prevertebral fascia, after breaching the prevertebral fascia, after opening the prevertebral fascia to work on the paravertebral muscles or the vertebrae, this is the work of our colleagues of spine surgeries. The Barrett's ligament is known as the posteromedial condensation of the pretracheal fascia, where it hides the recurrent laryngeal nerve behind it in a very close association, which in surgery is a very important step to save the recurrent laryngeal nerve from being injured by cautery or by a stitch, because we have to have a stitch or a tie in the Barrett's ligament because it always carries a very small artery and a very small vein, so they have to be controlled to prevent bleeding, and then we can then remove the thyroid lobe from the trachea. Lastly, we have to have an idea about the microanatomy or the histology. As we have already said, the thyroid gland is formed of follicles. Each follicle is formed of follicular cells. In between the thyroid output, the thyroid secretion is the colloid. The thyroid hormones, stored in the form of a colloid. And then in between the follicles, there are blood vessels, septi of the capsule, of course, macrophages, and the parafollicular cells or C cells of neural crest origin. This is a very simple idea about the histology of the thyroid glands. Of course, the size and the shape of these follicles are affected by the degree of activity the gland is experiencing, whether it is in a euthyroid state, in a hyperthyroid state, or in a hypothyroid state. And as we can see, this concludes the first part of our lecture, through which we have tackled these points as regards the anatomy of the thyroid gland. Thank you very much for your attention, and we will continue the physiology and investigations of the thyroid gland in part 2 of this lecture, inshallah. Thank you very much.